Good morning. Before we get started, I had a couple of housekeeping items to talk with the group about. So we're trying something new this year with Grand Rounds. We're going to be taking a hiatus so that we will not be having Grand Rounds in July and August of this summer. We will be restarting the week after Labor Day. So same time, same place, but we're just going to try something different this year and take a break for summer. The second item is that leadership is going to be transitioning this fall. So Dr. Jesse Powell is going to take over at the helm of Grand Rounds Planning. Dr. Powell was a chief resident here and is in medical education. So he'll be taking over the planning of Grand Rounds. It's actually planned through the end of the year, but he'll take over for 2019. Both myself and Dr. Wernick will be involved in helping to kind of guide him in that new role, but he will be taking over and he'll do a great job. I have all the confidence in the world that we'll have a great series moving forward. I'm not leaving, I'm just, endocrinology is moving out. We have a separate department and we're moving into a different location down the street. So that'll be happening soon too. So if anyone has questions or concerns, I'm happy to answer them. We'll be having a couple more Grand Rounds through the end of June, and I'll be here for all of those. But moving on to today's speaker. Dr. Lowenkopf did his medical training at Jefferson Medical College in Philadelphia, where he was involved in basic neuroscience stroke research, and after an internship here at Prof. Portland, he went on to do a neurology residency at Albert Einstein College of Medicine in New York City. He completed a fellowship in cerebrovascular disease at Washington University in St. Louis and helped to implement the university's acute stroke medical team response and conducted laboratory research on stroke. He joined Providence in 2000 and started the Providence Stroke Center. He supervises inpatient stroke unit at Providence St. Vincent and has implemented a similar model here at Prof. Portland. Both units have received national certification as primary stroke centers, and Providence St. Vincent was the first hospital in Oregon to receive that designation. He's a co-investigator for a $1.4 million grant from the CDC and has a statewide stroke registry in Oregon. We're really happy to have Dr. Lowenkopf come speak to us today about updates in stroke.
Good morning, and thank you for the very nice introduction. As Liz was saying, this is me coming back to where I did my internship, so I'm almost a little bit intimidated about speaking publicly because I know there are attendings out there who are going to tell me I don't really know what I'm talking about. Hopefully you'll get a different impression today. So the overarching purpose of this talk is to provide information to those of you who take care of stroke patients both in the inpatient and outpatient setting, focusing on the questions that we get asked most often, so practical information, but presenting the evidence that tells us what the appropriate thing to do is. So thank you for your attention in advance. I have no financial disclosures. So this is really patterned, as I just mentioned a moment ago, on the most frequently asked questions that I get from providers, and then again, as I said, showing you the data. So what is the appropriate antiplatelet management when my patient has a stroke or a TIA on aspirin? That's probably number one with a bullet. Around atrial fibrillation, what is the appropriate timing of anticoagulation after an ischemic stroke? What is the adequate duration of cardiac telemetry monitoring to exclude paroxysmal atrial fibrillation? So very clear data that suggests that anticoagulation is the appropriate therapy in the vast majority of cases if someone has a TIA or stroke with AFib. How long do you have to monitor somebody to determine whether they have that condition? When is it appropriate to offer one of the novel anticoagulants, and not so novel anymore, they've been around for a few years, but still for most providers, they're still getting familiar with them. What is the appropriate stroke prophylaxis when a transthoracic echocardiogram or a transesophageal echocardiogram shows a patent foramen ovale? And that's been in the news quite a bit lately. And what is the optimal management of asymptomatic carotid disease? So most of this is about stroke diagnostic workup and secondary prevention. But I also, because of the bombshell that we've had this year in acute stroke care, what is the new guideline that extends the acute stroke time window out to 24 hours? So just a little bit of background. Excuse me, I'm getting over a cold. A little bit of background about stroke and terminology. So there are about 800,000 strokes in the US every year, one every 40 seconds. It's the 5th leading cause of death in the United States, and it is the #1 cause of long-term adult disability from hospital discharge, about 6.5 million stroke survivors. So again, just to focus on terminology a little bit, stroke subtypes and incidents. This is from a large stroke registry. We have our own stroke registry, which has over 80,000 patients in it and includes all the Providence and Swedish hospitals from Alaska to Southern California, and the data is similar. So roughly 85% of strokes are ischemic, about 15 are hemorrhagic. Of the hemorrhagics, majority are intracerebral hemorrhage, a smaller percentage subarachnoid. Of the ischemic strokes, about 20% come from atherosclerotic cerebrovascular disease, referred to as thromboembolic strokes, coming from large arteries like the carotids or the vertebrals. Small vessel disease, which I'll give a little bit of detail in terminology in a moment, about 25%, and then cardiac, whether from AFib or dilated left ventricle, as in a cardiomyopathy, about 20%. So just reviewing that, atrial fibrillation, left atrium, carotid, large vessel disease, left ventricular, typically with ejection fractions below 30% or significantly diminished with apical akinesis. Intracranial atherosclerotic disease is still considered large vessel when it involves vessels like the middle cerebral, anterior cerebral, posterior cerebral arteries. Aortic arch tends to be under-recognized as a source of thromboembolism. And then small vessel disease. And this is a useful concept in thinking about cerebrovascular disease to understand. So you have large vessels, and the only arterial bed in the body where you go from a very large caliber vessel to a very small caliber arterial vessel is in the brain. And just by simple flow dynamics, rheology, the study of flow, if you go from large caliber to small caliber without a graduation, there's naturally increased pressure in a short segment of these vessels, which leads to atherosclerosis, and you get what are called small vessel strokes that take place in characteristic locations. It also leads to small microaneurysms. So you get what are called Charcot-Bouchard aneurysms, dilations of the vessel, and when you read a radiology report and it says a hypertensive bleed, there are classic locations where these take place because they rupture and bleed in typical places like the pons, the putamen, usually referred to as the basal ganglia in radiology reports. And this is what small vessel disease looks like. So true microvascular infarcts are these little lacunar strokes, discrete areas that have CSF hypodensity. But if you look at this white matter change and you look at these white matter changes, these are not discrete infarcts like where a large or a small vessel has been occluded and tissue dies. These are what on most radiology reports in people over the age of 60, they call chronic microvascular disease or small vessel white matter changes. And we get probably 1 or 2 consults a month in our clinic because people are interpreting these as strokes. Strictly speaking, they're not. The pathophysiology of these white matter changes is a talk in itself, which I will spare you. But that's what people are talking about, and they're very common in people with risk factors. So if you see this on an MRI or on a radiology report, your take-home is I should be very focused on my patient's risk factors. And aspirin is adequate for stroke prevention, but hypertension, diabetes, smoking, hyperlipidemia. This is what one of those small vessel bleeds looks like acutely. What's bright on a head CT is bone or blood. Classic location here. And this is to be differentiated. This is an MRI that shows a large vessel wedge-shaped occlusion in contrast to the small vessel disease. So background for discussion of that will be referred to further in the talk. So for secondary stroke prevention, It should be this simple, but as we all know as clinicians, there are infinite shades of gray. So what is the initial cerebrovascular event? If it's a large or small vessel atherosclerosis, if they have symptomatic carotid disease, they will or will not get a carotid endarterectomy. If it's an unknown etiology, you're choosing antiplatelet therapy. If it's cardioembolic, primarily atrial fibrillation, and in selected cases, dilated cardiomyopathies with low ejection fractions, you're going to choose an anticoagulant. But how do we get to those decision points? And amongst antiplatelet therapy, how do we choose? So what is the appropriate antiplatelet management when my patient has a stroke or TIA on aspirin? As I said, probably the most frequently asked question. These are, this is a partial list, but of the principal trials that have been collected over time to answer the question about secondary stroke prevention, antiplatelet agents, anticoagulants, and a list of some of the trials. I won't go through all of them. The principal antiplatelet therapies that we are familiar with are aspirin, clopidogrel, brand name is Plavix, and then the combination of aspirin and extended release dipridamol, both antiplatelet agents, brand name is Agronux. I didn't do anything. There we go. So this is usually the net effect of the discussion of antiplatelet therapy to an audience. It will be a little bit soporific, but I think it's important to be aware of the studies to make fairly clear conclusions at the end. So I'm going to take you through the studies. And just as a reference point, this is the primary practice guideline that I'll be referring to for recommendations. This is from the American Heart Association Stroke Association, most recently published in 2014. No significant changes have taken place in terms of the guidelines, although I will show you some studies that may affect the next iteration of these guidelines. This is published in the journal Stroke. So, does the dose of aspirin matter? And what the data tells us is the magnitude of benefit is similar for doses ranging from 50 milligrams, which is the European small aspirin, to 1,500 milligrams. In contrast, the toxicity does vary by dose. The higher the aspirin dose, the more likely risk of bleeding, primarily gastrointestinal bleeding. So I find this phenomenon fairly interesting in medicine because we have this large registry. We see patients who come in the hospital on a baby aspirin, and most of them will leave on either a higher dose of aspirin or on clopidogrel. And that's a symptom, I think, of physician psychology, which is if something didn't work, we have to do something different. But what I'm saying is the data says it doesn't make a difference. There's no data that suggests that a higher dose of aspirin is better. Now, one question that frequently comes up is what about platelet resistance to aspirin, which is not a standard commercially available assay, but you can study patients, and you can detect that maybe 20 or 30% of patients have a platelet resistance to the effects of aspirin. Studies have been done, which I won't go into here in the interest of time, that show that if you select those patients and give them higher doses of aspirin or switch them to another antiplatelet agent, there's no benefit, and actually the incidence of side effects and bleeding actually goes up. So limited studies suggest that even in the patients with platelet resistance to aspirin, it doesn't help to increase the dose. This will not stop patients who are on 81 milligrams of aspirin leaving on 325, but I'm telling you the data doesn't support that practice. And again, this is a further recommendation that says that patients who have ischemic stroke or TIA while taking aspirin, there's no evidence that increasing the dose has added benefit. But no single agent or combination has been adequately studied in patients who have had an event while being on aspirin. So what they're saying here is we don't have enough data. I would say that we probably do based on what I'm about to show you. So the first study that tried to suggest that something was better than aspirin was the Capri study, which was published in The Lancet in 1996. And they took patients who had stroke, MI, peripheral arterial disease, and they put them on either aspirin at the 81 to 325 dose versus clopidogrel at 75 milligrams. And what they found with the endpoint of the composite of stroke, MI, or vascular death is that there was an 8.7% relative risk reduction for the patients who were put on clopidogrel relative to aspirin. And this changed practice. What the study showed was that there was a decrease in the outcome events on patients on clopidogrel. There was a decrease in bleeding that was small, and so there was a net decrease in events. And as I suggested, this changed practice. However, what the data showed on closer scrutiny was that the driver for the combined endpoint were patients who had peripheral arterial disease. So patients who had strokes or MIs did not have a reduction in the primary endpoint of this study. Nevertheless, in prominent journals, the manufacturers of clopidogrel promoted this. The FDA said you can't do that because the data says it doesn't reduce the incidence of stroke compared to aspirin. The manufacturer didn't comply with the FDA's recommendation. They received a fine, and they said, well, the fine certainly is manageable relative to the revenue that we're generating from the sale of the drug. So this represents, in my mind, a triumph of the art of advertising over the art of medicine. But it really did change practices. The next question was, what would, if really there's no difference between aspirin and clopidogrel, what happens if you take clopidogrel and aspirin compared to aspirin alone for secondary stroke risk reduction? This was the MATCH study. And I'm taking you through these studies one at a time so that you see the conclusion, which I hope we'll arrive at, which is that aspirin alone seems to be as good as anything else. So MATCH had about 7,500 patients in it, stroke or TIA plus a vascular risk factor, clopidogrel plus aspirin versus clopidogrel alone. And I'll show you the results in a second, but there was no difference in stroke, MI, or death or stroke outcomes, and there was an increased risk of bleeding. So here's this study summarized. Oops, let's go back. And the gist of it is that roughly the same number of events, slightly lower in the clopidogrel aspirin group, more bleeds, there was a net increase in events. It was considered a negative study. A variation on that, again, this was the Charisma study, 15,600 patients who had a TIA or stroke with multiple cardiovascular risk factors. This was clopidogrel plus aspirin in contrast to the previous study versus aspirin alone. The previous one was versus clopidogrel alone. The primary endpoint was a composite cluster of ischemic stroke, MI, or vascular death, average patient follow-up 28 months. So again, there was a slight decrease in the ischemic events. There was an increase in the bleeding events. One event avoided for 1,000 treated for 2.3 years. So again, considered a negative study, the combination. The next drug that came on the scene roughly the same time in the 90s was the combination of low-dose aspirin with extended release dipridamol given as a BID dosing. 6,600 patients with recent cerebrovascular event. This study was done actually at a time when you could have a placebo instead of aspirin as the control. They had the combination of aspirin and extended release dipridamol versus extended release dipridamol alone versus low-dose aspirin, 50 milligrams daily total versus placebo. Primary endpoint was stroke, death, and stroke or death together. Secondary endpoint, 2-year follow-up. And this did change practice. There was a decrease in the combined endpoint. There was a slight increase in bleeding, but there was a significant decrease in event, which was absolute risk reduction was 3%. And this changed practice, at least for stroke neurologists. Patient had headaches, they had stomach upset with this medication, but we felt it was a better drug than aspirin. There was a second iteration of this aspirin plus dipridamol versus aspirin alone. There was no placebo arm. significantly smaller study. Primary endpoint was the composite outcome of stroke, MI, vascular death, major bleeding, 3.5-year follow-up. And briefly summarized, again, this similar to the ESPS2 study, a 3% absolute risk reduction. So it supported this change in behavior for secondary stroke prevention. Then came the PROFESS study, which I'll give you a flash forward, sort of muddied the overall picture. This was a study that looked at head-to-head brand name comparison of extended-release dipridamole plus aspirin versus clopidogrel with telmisartan. And this was in the era which I think we're still in to some extent, where ACE inhibitors and ARBs were considered to have additional vascular protection benefit independent of just their blood pressure lowering properties. And so they did a 2-by-2 array here of the two study drugs with or without telmisartan. I'm not going to go into the telmisartan data in any detail, but it didn't show any benefit independent of blood pressure lowering based on the class of drug. But they did have this large group of patients who were on extended-release dipridamole plus aspirin versus clopidogrel alone. This was a larger study, a very large first stroke study, 20,000 patients, 2.4-year follow-up. Primary outcome, as opposed to the others, was not the cluster of vascular events, but first recurrence of stroke. The secondary outcome was the composite. It was ultimately designed to demonstrate non-inferiority. Here are the inclusion criteria. It's hard to draw two lines closer together. So aspirin and extended-release dipridamole versus clopidogrel, you can see these two lines go. This is percent recurrent stroke, the primary endpoint, and time. And you can see there was virtually no difference. So if you compare the clopidogrel versus the aspirin and the extended-release dipridamole, there was a net decrease in events, in 25 fewer ischemic strokes in the aspirin extended-release dipridamole, and I can't wait for this part of the talk to be over so I don't have to say that too many more times. There was a net increase in bleeds, and there were actually 17 more strokes. So if you think about what I've shown you so far, the initial clopidogrel data, the combination treatment, the clopidogrel didn't seem to be better than aspirin. The extended-release dipridamole seemed to be better than aspirin, but in this study there were many more hemorrhages, and this was a larger study. So the net conclusion was that there was really no difference between clopidogrel. In terms of the secondary endpoint, again, two lines very close together. This was before this study, which was called the PROFESS study. So head-to-head, aspirin versus extended-release dipridamole, there seemed to be benefit for that combination. Head-to-head for clopidogrel, there was no difference. And this was an inference, hence a dotted line, that there was no difference between these two. Afterwards, there was no significant difference from the meta-analyses of all the studies between any of these agents. So here we were in 2008 in the New England Journal of Medicine, and coming to this conclusion, which I think summarizes a useful, practical take-home. In the case of PROFESS and the tangle of related trials, and this was an editorial that came out with the study, enlightenment might be expressed simply as a haiku. For stroke prevention, use an antiplatelet drug, treat hypertension. So what does that mean? It means basically if you leave a patient on aspirin, you're doing fine, but you should really be focused on risk factor management. 5 points of systolic blood pressure probably have more bearing on the risk of recurrence than which antiplatelet drug you choose. Gets a little bit cloudier because there are clinical contexts where there's an argument being made to use dual antiplatelet therapy. So intracranial atherosclerotic disease has a long history in stroke. We used to anticoagulate these patients based on retrospective data. Then we did a prospective study that was called WASID that showed that there was risk but no benefit to anticoagulation. So then we went back to antiplatelet therapy. Then the era of stenting came in, and there was a study called the SAMPRA study, which I'll show you in a moment, where patients who had symptomatic intracranial stenoses that were proven by angiography to be 70% or higher were randomized to endovascular treatment, which meant angioplasty and stenting, and all those patients received dual antiplatelet therapy and aggressive risk factor management. And it was one of these eye-opening studies where the medical arm turned out to be much better than the interventional arm, which is why you don't see a lot of patients getting intracranial angioplasty and stenting. So again, this was aggressive risk factor management, systolic blood pressure less than 140, closely monitored, diabetics less than 130, LDL-C less than 70. But all these patients, including the medical control arm, received both aspirin and clopidogrel. And there was a dramatic risk reduction in the medical arm, such that even in the hands of, these were very experienced interventionalists, that the dual antiplatelet therapy medical arm outperformed the intervention by far. I don't have data slides on that. So that it became the recommendation, if you have symptomatic intracranial atherosclerotic disease, that you get dual antiplatelet therapy. And we do that, but there was no control arm. There was no single antiplatelet. But Sampras is what drives dual antiplatelet therapy for symptomatic intracranial atherosclerotic disease. What about short-term risk reduction from dual antiplatelet therapy? So the CHANT study, which was published in 2013, was conducted exclusively in mainland China, and they put patients on aspirin and clopidogrel for 21 days and showed a reduced 30 to 90-day incidence of TIA and stroke. So in the US, we said, okay, this is a separate population. It's not US-based. Let's do this study in the United States. And I presented this talk just about a month ago, and this study had not been published. And then it was published about the next day. I think it was May 16th. So this is the clopidogrel and aspirin in acute ischemic stroke and high-risk TIA. We participated both at Proud Portland and St. Vincent's in this study. And patients were put on aspirin and 75 milligrams of clopidogrel for 90 days and looked at the incidence of TIA or stroke in that patient population. And here's the data. So here's the clopidogrel plus aspirin group, and here's the aspirin group for the primary efficacy outcome, which was the composite of ischemic stroke, MI, and death from vascular disease. And you can see there was a statistically significant difference, not huge, 1.5%. Which seems to suggest, and the concept here is that if you have atherosclerotic plaques, there's a vulnerability for recurrent events that maybe aggressive dual antiplatelet therapy will reduce the event rate. However, there was a higher hemorrhage rate as well. And the data was not presented in terms of the chronology of the events, but the investigators suggest that the benefit is upfront and the hemorrhage risk is actually delayed. So we don't know how to take this result, which has been published in the last month, and put it into practical practice guidelines. We'll await for professional organizations to inform us based on the data, but it looks sort of like a push in terms of benefit and bleeding risk. Perhaps combined with the CHANCE data, there will be a recommendation that for the first 30 days after a small stroke or a TIA, you go on dual antiplatelet therapy. Stay tuned. All right, I don't see too many closed eyelids after the stroke neurologist lullaby. We'll move on to atrial fibrillation. What is the appropriate timing of anticoagulation after an ischemic stroke? What is the adequate monitoring? When is it appropriate to offer one of the NOACs? Is it ever appropriate to anticoagulate after intracerebral hemorrhage? So most of you are probably familiar with CHAD scores or CHADS-VASC scores. This CHADS-VASC has supplanted CHADS in most clinical settings. Basically, you get points for your risk, and based on having a certain number of points, there's benefit, increasing benefit for anticoagulation versus antiplatelet therapy for secondary stroke risk reduction. There are some points of criticism. Is being a woman as significant as having hypertension? And then if you look at the actual linear risk, although the points seem to correlate fairly closely, when you get to 8, it actually drops and then goes up to 9. So not a perfect tool, but still what we use. So what about capturing paroxysmal atrial fibrillation? This is a slide I'd used previously. 2/3 of the cases of AFib are paroxysmal, same risk of stroke that used to be the conclusion. That has now been supplanted with this idea of what is the burden of atrial fibrillation. The longer duration of monitoring, the more likely you will detect atrial fibrillation. And I'll come back to this burden concept in a second. So the methods of capturing paroxysmal atrial fibrillation: non-invasive EKG, mobile continuous observation telemetry, the Zio patch, which is stuck on the chest, and there are other devices out there which basically monitor for atrial fibrillation. The challenge is, if you look at all these studies and try to compare them, the definition of atrial fibrillation varies significantly. There are invasive, there's an implantable loop recorder, which is very small, a minor procedure where it's just stuck under the skin. It can record, I believe, out to 3 years, and pacemakers and defibrillators have recording modes. One of the things I noticed in looking at some patients just yesterday in clinic is very often people will be put on an event monitor. I tend to shy away from those because you're basing the report on a patient pressing a button based on whether they're having symptoms or not. So if they feel tachycardic, or they feel lightheaded, or they feel their heart fluttering, they'll push a button, and you can't rely on that. Patients can be in atrial fibrillation and have no idea. So you need a continuous loop recorder to really detect whether someone has paroxysmal atrial fibrillation. With the caveat of saying that the definition of atrial fibrillation varies, these are rough numbers. So if you admit someone to the hospital for 2 to 3 days, you'll capture atrial fibrillation if they have it 3% of the time, a 48-hour Holter 2 to 3% of the time, a 30-day monitor 11 to 16% of the time. But you can see the longer you monitor, the more likely you are to detect it. Now, you will see device manufacturers who present numbers that are at variance with this. They're not dramatically at variance, but again, it depends on how you define atrial fibrillation. This is a paper that was in circulation in May of this year talking about the burden of disease, which very clearly said that it's paroxysmal atrial fibrillation is not as high a risk as chronic atrial fibrillation. So the longer you're in AFib, the more likely you are. But this was actually more of a phenomenological discussion rather than giving us specific definitions, because we don't really know if you're on a monitor and you have an hour of AFib or 10 days, what the relative risk is. But the way that they're talking about defining the burden is the number of episodes, the longest duration of the episodes, and then the percentage of time that you are in atrial fibrillation. Again, connecting that to risk is a work in progress, but sort of redefining our concept of how we think about atrial fibrillation. Questions that remain: what duration of monitoring is enough? What duration or frequency of atrial fibrillation on a monitor is enough to increase the stroke risk and merit anticoagulation? And then another approach which is being tried. So the manufacturers of the novel anticoagulants have said, well, if you have a non-small vessel stroke, like the MRI I showed you where there's a large infarct, and you don't have any vascular disease, and you have an echocardiogram which shows a relatively normal ejection fraction, why not just put those patients on the novel anticoagulant? Because probably they have AFib, and you're going to spend weeks doing transesophageal echocardiograms and extended monitoring. Just put them on the novel anticoagulant, which I think some practitioners do, and keep your fingers crossed. The Navigate ESIS study, which looked at rivaroxaban, also known as Xarelto, showed that there was no clear benefit, but the bleeding risk was significantly increased to the point that they stopped the study. The RESPECT ESIS study is ongoing, so we don't know the answer to that. Just a very brief, and again, this could be a talk in itself, when I think about the novel anticoagulants, dabigatran, rivaroxaban, and apixaban, from the primary studies that were done comparing them to warfarin, for stroke prevention, dabigatran and apixaban were better. Rivaroxaban was equal in terms of bleeding risk, roughly equal. Apixaban was better. The advantage of rivaroxaban is single-day dosing. The others are BID dosing. And there are a lot of questions and a lot more to it than that, but I think that's a useful guide. Patients to consider for novel anticoagulants: intolerant of warfarin, unstable INR. We're doing a research project right now looking at patients with atrial fibrillation in the Providence Health System, and we've done a sampling of a few thousand patients. Patients who are on warfarin in our system, if you just take a snapshot of INR, only 42% of them are in a therapeutic range at any given time. Unable to get an INR, so patients with agoraphobia, I've had a few of those. Offer it to new patients. For stable patients, I might bring it up that if they ask a question, but I don't think I'm going to transition patients, and there are issues of cost as well. So you could certainly offer it or mention it. I don't switch patients who are doing very well on warfarin. What about the timing of anticoagulation after stroke with AFib? So this is an actual patient who was hospitalized at Proud Portland. A 76-year-old man with AFib presents with 8 hours of left-sided weakness and slurred speech. He had atrial fibrillation. His provider put him on warfarin, fearing that there was going to be a recurrent event. This is his initial head CT, and this is what his head CT looked like after he developed a headache and became unresponsive. So how do we approach this question, timing of anticoagulation after stroke with AFib? So you have to ask two questions to reach your answer. What is the risk of recurrent stroke off of anticoagulation? What is the risk of hemorrhagic transformation on anticoagulation? So the timing, the risk is about 5% over 14 days. And this is from a clinical trial where it was actually the TPA treatment study where they collected data on atrial fibrillation, and they found that there was roughly a 5% chance of having a stroke if you had AFib over the first 2 weeks. There was a 3.9% chance of having a stroke if you didn't have AFib. What correlates with the risk of hemorrhage? The size of the stroke, how recent it was, the degree of anticoagulation. So we use low molecular weight heparin routinely for DVT prophylaxis in patients with even large ischemic strokes, the patient's age, a history of diabetes, a history of hypertension, and the presence of those microvascular or white matter changes that I showed you on an MRI earlier. So there's no formula, but these things additively correlate with the risk of hemorrhage. So what the professional guidelines tell us is that for most patients with a TIA or stroke, it is reasonable to initiate oral anticoagulation within 14 days after the onset. So if you wait 14 days, you're complying with the guidelines. For larger strokes with high risk of hemorrhage, you can wait longer. What we tend to do, if it's a TIA or a very small stroke, we'll tend to start them on anticoagulation. If it's just a TIA, no symptoms, we'll start them on the first day. If it's a small stroke, we'll sort of say, okay, 7 to 10 days. But that's, again, using our psychology and not data. You can wait up to 14 days. So hopefully that's helpful. So here's a very commonly asked question. What is the appropriate stroke prophylaxis when an echocardiogram shows a patent frame in ovale? And again, I'm going to show you some clinical trial data. This has been a kind of a thorn in the side of stroke neurologists because PFOs are very, very common. 20 to 25% of people will have one if you do a bubble study. And the person who writes the guidelines for the American Stroke and Heart Association for Stroke, who's the chairman of neurology at University of North Carolina, and one of my mentors, I said, Dr. Powers, what do you do with this? He said, I tell my residents not to order bubble studies. Problem solved. But it's not that simple. So what is the incidence of patent frame ovale? This is from autopsy studies based on the age of the patient at autopsy, and you can see 20 to 30% of patients will have a PFO on autopsy. The rate of recurrent stroke under medical treatment in patients with PFO is extremely low. So for all the anxiety about whether to offer this, when is it significant, is it related to the cause of stroke, roughly 2% per year from a large number of studies. What got things rolling about PFO closure was this study that was published by Jean-Louis Moss in 2001 in the New England Journal of Medicine, where he looked at patients who had transesophageal echocardiograms, and they had an atrial septal aneurysm, which an atrial septal aneurysm by definition is just a bowing of the atrium during cardiac contraction, and they look at the degree of movement of the wall. So 0 millimeters is no atrial septal aneurysm, and you can imagine the grading of this is a little bit challenging. By most conventions, it's 10 millimeters of bowing qualifies as an atrial septal aneurysm. So it's just a bowing of the atrial wall. It's not a true aneurysm in the sense of the word. So atrial septal aneurysm alone, no patent foramen ovale or atrial septal aneurysm, a patent foramen ovale alone, or the combination. And this was the risk of having a stroke or free from stroke or TIA over out to 4 years based on whether you had these. So this suggested that if you had a PFO and an atrial septal aneurysm, you were at higher risk of stroke if you were just taking aspirin. So when I came here, I used to look like that. And these are the types of devices that they actually used to use to close the holes in the heart. And I remember seeing patients who had in the late 90s, their PFO closed with this device, and they were seeing me because their cardiologist was saying, what do I do about the fact that one of these arms is now going up into and messing with the aortic valve? So the initial designs were not very sturdy or effective in closing the PFO hole. So questions that we ask: is PFO causally related to stroke? What is the best medical management for secondary stroke prevention in patients with PFO? And is there a role for mechanical PFO closure for stroke prevention? So again, here's the atrial septum. All of us in utero have this communication. In 75 to 80% of people, it closes in the first few days of life, but in that 20 to 30%, it remains open. And so the question is, how is that related to stroke? Because it doesn't seem likely that a flow dynamic around there, is, like with atrial fibrillation, is going to cause a clot to form. Is it paradoxical embolism? That's the inference that most people make, that there's a DVT that somehow passes through the hole, but in the majority of cases where you look for deep venous thrombosis in patients with PFOs, you don't find anything. So this was the bombshell, if you want to call it that, that came in the New England Journal of Medicine in September of last year, where there were 5 separate articles published on PFO closure. 2 of them were editorials, 3 of them were clinical trial, published of clinical trials, which I'll share with you the data. So these are relatively small studies. And again, the other thing I would keep in the back of your mind that I said initially is the incident rate of stroke in this population, when you have a PFO, is extremely low. So a small number of patients, it's tough to reach statistical significance. The key inclusion was being younger, 16 to 60 in this study, PFO with greater than 30 bubbles, and the atrial septal aneurysm of greater than 10 millimeters. Key exclusion was stroke of known etiology. Medical therapy was aspirin versus warfarin, and the mean follow-up was 5.3 years. And you can see that there was a small benefit for PFO closure versus antiplatelet therapy alone. And here they're just magnifying the difference, but you can see it's a very small difference. In this study, in the PFO closure group compared to antiplatelet, there were no events in the closure group, and there were, 14 events in the antiplatelet group. When they compared anticoagulant to PFO closure, there was no benefit. So what about the complication event? There were complications for device placement, and then I would focus on this, that there was a increased incidence of atrial fibrillation as defined as was classified as cases that required treatment for more than 1 month. So there was roughly 5% of the patients developed atrial fibrillation from the device placement. The REDUCE study, this was a 2-to-1 randomization to PFO closure versus antiplatelet therapy. They had 2 primary endpoints, 24-month event-free and 24-month silent and clinical stroke. So one was, did you have symptoms? And the other was, did you have symptoms or did you find on an MRI or a CAT scan evidence of a stroke? Again, a relatively small number of patients, all younger. No key exclusions here. PFO closure versus antiplatelet, mean follow-up was 3.2 years. Sort of a similar graph to what we saw before. Looks like there is some benefit to PFO closure versus antiplatelet therapy alone. In this study, in terms of adverse events, again, atrial fibrillation, roughly 5% versus the medical group. And this is, again, requiring treatment. Finally, the RESPECT study, which we participated in, was PFO closure versus medical therapy, ischemic stroke, slightly larger cohort of patients, again, younger patients, stroke within 6 months. Key exclusion was stroke of known etiology and a roughly 6-year follow-up. And again, a similar graph when compared to antiplatelet therapy. The medical group in this study could have been antiplatelet therapy or anticoagulation. It wasn't controlled by the study, which is unfortunate. Again, there was a statistically significant reduction in events, both small in the medical therapy group versus recurrent ischemic stroke. There was recurrent ischemic stroke that became of known etiology. So if it was of in undetermined etiology, there was also a difference. And atrial fibrillation was not commented on in that study. So what are the take-homes from this fairly complex data set of different studies? PFO closure significantly reduced stroke incidence in young patients with cryptogenic stroke when compared to antiplatelet therapy. No benefit compared to anticoagulation. The number needed to treat to prevent one stroke, if you look at the composite of these studies, was 20 to 28 to prevent one stroke at 5 years. So a pretty big number of treatments with a 5% risk of atrial fibrillation. So how do you take this into practical patient care? In patients with younger patients with cryptogenic stroke and a PFO, it can be considered in patients less than 60 after thorough workup, including transesophageal echocardiography and hypercoagulable studies. So the studies show some benefit. I really don't think we understand exactly which patients it's going to benefit yet. It's reasonable to offer in younger patients with cryptogenic stroke. Okay, carotid disease. We're coming down the home stretch here. So most people are familiar with data from the 1990s, the 2-year risk of stroke with symptomatic carotid disease. The NASCET study and the European equivalent showed that with higher degrees of stenosis, surgical intervention reduces the risk of stroke significantly over medical management. The controversies: is carotid ultrasound an adequate measure of carotid stenosis? In a center like this one that has an ultrasound lab where there's a correlative study, whether it be conventional angiography or CT angiography, to suggest that the carotid ultrasound is accurate, it's usually adequate. If you're in that in-between zone where it's 50 to 69% or less than 60% by what are called the ACAS criteria, you might want a confirmatory study. Is there an optimal timing of surgery? Yes, I'll show that in a second. And what is the best management of asymptomatic disease, which I think is a really important question, and I'll touch on that briefly. So this is from the NASCET and the ECST study, the European Carotid Surgery Trial. And this showed the benefit of the endarterectomy versus medical management based on how long it was since they had their event. Less than 2 weeks, 2 to 4 weeks, 4 to 12 weeks. And you can see the benefit correlates. So if a patient does not have a strong contraindication to early surgery, they should have it. They'll get greater benefit in terms of stroke risk reduction. What about asymptomatic disease? This is from the asymptomatic carotid artery surgery trial, which was published in the 90s. And they showed that if you had a 60 to 99% carotid stenosis, the absolute risk reduction was 5.9%, the relative risk reduction, the number needed to treat. But there's been a lot of questions asked about this study. So if you look at the ACAS study right here, and you look at that's the surgical arm and the medical arm, there was not a statistical significance until 4 years, although you see a difference. It was not statistically significant until a lot of patients in the medical arm did a lot worse, and a lot of that was just death from a non-stroke cause. So people questioned the surgery for asymptomatic disease. In addition, there's an increasing data set as from the SAMPRA study where we think that aggressive medical management for symptomatic or asymptomatic vascular disease reduces risk perhaps better than interventions. So the management of asymptomatic carotid stenosis, 3% per year stroke risk from previous trials, 5% with higher degrees of stenosis. This is the medical arms that fed into the surgical trials that I mentioned already. Recent data shows, again with better medical management, that the stroke risk is probably much lower. So that would make you call into question whether surgery for asymptomatic disease is beneficial. A recent meta-analysis showed decreased stroke rates 2.83% before 2000, 1.13 per year after 2000. I can tell you in the Providence system, most carotid interventions, whether they're stenting or surgeries, are done on asymptomatic patients. So this is where we are now, and we are participating in the CREST-2 study, which is randomizing patients to either stenting versus medical management or surgery versus medical management. And I think we really have clinical equipoise. So if you have patients with carotid disease that's greater than 70% and it's asymptomatic, please call us. We're trying to get patients into this study, and our vascular surgical colleagues are supporting this effort. The last thing I'm going to talk about is this non-secondary prevention topic, which is this landmark change in how we can treat acute stroke. This is from the stroke guidelines, which were presented in January of this year and updated in March. In patients with acute ischemic stroke in the 6 to 16 hours since last known normal, who have a large vessel occlusion intracranially in the anterior circulation and meet other dawn and diffuse eligibility criteria, which I can answer questions around but won't go into, mechanical thrombectomy is recommended with a level 1A recommendation. And so just briefly talking about stroke care, 1996 IVTPA was improved, which got patients with moderate strokes who presented within 3 hours from patients surviving with minor or no disability went from 33 to 50% with treatment, so an absolute benefit of 17%. In 2004, the first thrombectomy devices were approved. In 2013, at the International Stroke Conference, 3 studies on these thrombectomy devices were presented that demonstrated futility. In 2014, 3 studies demonstrating efficacy of the new device. What was the difference? So it was what are called stent retrievers. So these were devices that were initially conceived of as like the Sampras stents that I talked about before. You put them up in the brain, you have a vessel with atherosclerosis, you dilate them, and they keep the vessel open. But what they found was that the radial strength of these stents was not adequate to maintain the stent open, and they were collapsing. But when they pulled them out, they said, wow, thrombus, plaque, that's kind of cool. Maybe we can use this in stroke. So what the study did was to take these devices with a hollow lumen catheter so that you could actually insert it into the clot and get distal flow. You'd expand your stent, set a timer on for 5 minutes, and then pull back. And 70% of the time with one pass, they were pulling the offending clot out, whereas the previous devices were much slower, multiple passes, and were not as efficacious. So this was a huge game changer. In 2017, the DAWN study was presented, and in 2018, the DIFFUSE study, which used a different metric for identifying patients who might benefit from revascularization who were having acute ischemic strokes. So the DAWN study went out to 24 hours, and what we were using is a blood flow imaging technology. So again, I won't go into all the details, but what we're looking at is a CT scan of the brain, and we're looking at, in this case, cerebral blood flow less than 30% of the cerebral blood volume. And what that correlates with is tissue that is destined to die, or the core of an infarct. The green area is what is called Tmax greater than 6 seconds. So you inject the dye, how long does it take to get the maximal flow? In a normal brain, a second or 2. In an underperfused brain, it can take much longer than 6 seconds. But in the 6 to 8 second window, that was what was identified as salvageable tissue. And so now when patients come in who are up to 24 hours out, and they've got a large vessel occlusion, a distal internal carotid or middle cerebral artery occlusion, we'll take them for what's called rapid CT perfusion, And within a few minutes, we can get this image on our cell phones and in our radiology PACS system. And if the ratio of green to purple is 1.8 or greater, there's very good data that revascularization has benefit. And this study was stopped with 182 patients in it because the benefit was so dramatic. And the number needed to treat to get one good outcome was 2. So, just to summarize and conclude and open the floor to questions, what have I said? Antiplatelet therapy after stroke. Again, going back to the haiku, for stroke prevention, choose an antiplatelet agent, treat hypertension. Higher doses of aspirin does not have any clear benefit but increases risk of bleeding. Atrial fibrillation, ideally you would monitor for 30 days. The Zio patch is only 14 days. There's a limitation there. It's probably the Providence preferred continuous monitoring. NOACs are a good alternative to warfarin. Wait approximately 14 days to anticoagulate after a significant stroke. For asymptomatic carotid disease, there's clinical equipoise on whether to do a procedural intervention or medical management. Please refer to our trial if you have patients. Patent foramen ovale in stroke, PFO closure can be considered in patients under 60 with a cryptogenic stroke after a complete workup. Number needed to treat 20 to 28, 5% risk of AFib. That's it. So thank you for your attention. I hope I provided you something practical and useful for your practice, and I'll take any questions. Yes?
Regarding CEA after stroke, I thought discussing one of the slides said promptness of surgery had better outcome, but I thought that the standard practice by vascular surgeons was to wait 3 months after a stroke for surgery.
Well, I'm making an argument based on data against standard practice. I'm sorry? So the question was regarding the timing of carotid revascularization after stroke. The data suggests that I presented suggests that early intervention is superior. Standard practice of vascular surgeons is to wait. And I don't know that that's true. The vascular surgeons who I work around on both campuses, I believe, recognize this data on the timing, which was published in 2004. There is sort of a disinclination if someone has fluctuating symptoms or a very large stroke to wait. And the data, I mean, the critique of the data is that it was retrospective. They didn't prospectively look at patients, so were patients selected for early intervention based on having less severe strokes. But if you can comfortably, medically send the patient for revascularization where you don't think there's a really high risk of a complication from reperfusion, as an example, earlier is better. And there's not a compelling counter argument to that. There is old practice, but I think it's slowly changing. Yes?
So for a patient who presents acutely with severe vertigo with ataxia or posterior circulation stroke, what is the sensitivity of a standard CT-CTA, and are there any instructions for the radiologist who should be able to detect as far as the type of imaging and type of contrast? Obviously, MRI is much better, or we can't get an MRI.
Yeah, so if I'm hearing your question correctly, is how do we radiographically identify patients to try and differentiate between peripheral vertigo and ischemic stroke? So that's one of the big challenges. I don't care how much experience you have in trying to evaluate patients in the emergency department who have acute vertigo. The vast majority of patients with acute vertigo without any accompanying neurologic symptoms will be peripheral. And there are characteristics of the vertigo that sometimes are helpful in discriminating peripheral versus central vertigo. A CT scan is not, if it's an acute event, as in just an hour or two old, unless it's a bleed, is not going to give you any useful information. A CT angiogram can give you information that's suggestive but not definitive. If someone has vertebrobasilar vascular occlusive disease, it might be posterior circulation ischemia. An MRI, we do have rapid MR protocols, which you can actually see whether there's ischemia there. CT perfusion, the rapid software, is sometimes used for those because although it doesn't identify ischemia well in the brainstem, the cerebellar hemispheres, but there's no easy answer to that question. And our Our inclination is that if it could be a stroke is to treat it with IV TPA. You worry about hemorrhage risk, but if it's not an ischemic stroke, the actual risk of hemorrhage is very, very low. So there's no easy answer to your question. Yes?
With antiplatelet therapy for anticoagulation for atrial fib and CHADS2 VAS scores, do you reset the risk each year, or is it a cumulative risk?
It's a cumulative risk. So if you look at, if you have a CHADS VAS score of, say, it's 5% risk, annual risk, it's cumulative. So after 10 years, it's 50%.
But if you've gone, let's say, 10 years already without your stroke, what's your risk of the next year?
That's a very good question because there's a lot that isn't known about AFib risk and stroke. I mean, the CHADS VAS tool is useful, but it's a little bit crude. I pointed out some of the deficiencies in it. But there are patients who are 40 years old who have AFib, no vascular risk factors, and they have a stroke. And so people have tried to look at left atrial anatomy, flow dynamics in the left atrial appendage to say, are there characteristics that help augment your interpretation of the score? If you have someone who's 85 years old and has had AFib for 20 years and has just been on aspirin and their CHADS VAS score is 5, that's a tough one. And I don't want rat poison, right? Is the answer you tend to get. But you can only present statistical information, and then there's some empiric element to that. I agree, and I think there's a feature of AFib risk that we don't have our hands around. Yes, you're only allowed one question. I'm sorry. Okay. So maybe you can help me with this because there is significant radiation and dye exposure with CT perfusion. My practice has been if a patient's in the 6 to 16 hour time window, I start with a CT CTA because CT will tell you whether they have a hemorrhage. CTA will tell you whether they have a large vessel occlusion, and not all large vessel occlusions qualify. It's supposed to be distal internal carotid, middle cerebral artery, M1 branch, and sometimes M2 branches. We also will think about doing PCA P1 segment. So proximal clots may benefit from revascularization with a favorable perfusion profile. But it's a minority of patients who have clots in those locations. So I don't pull the trigger on the CTP unless I see a large vessel occlusion LVO, because I think I'm just ordering fewer studies that way. Does that make sense? But you're saying that if you do it that way, you're giving additional dye and radiation. It's probably not additional radiation because yeah. Yeah. Dr. Gilbert.
As usual, I'm so glad you're here to keep us up to date on all of the acronyms for all of those trials, which I can't keep straight in my head. But I'm sitting here thinking, if I'm a primary care provider and I've got the usual population of obese, hypertensive, hyperlipidemic patients, but they haven't had a stroke, they don't know if they're having intermittent atrial fibrillation, they don't know if they have, and I don't know if they have asymptomatic carotid disease or a paraminal valve. So it seems like we have to have you back to tell us how to prevent stroke in the first place and which patients are at high enough risk they ought to be on aspirin, low-dose aspirin to begin with.
Golly, is there anything I can say not to get invited back? So you're asking about primary stroke prevention rather than secondary stroke prevention, and the data there is actually a lot less compelling. I think there are guidelines around vascular risk factor management that are not just stroke related, but all peripheral arterial and cardiovascular disease. And risk stratification starts with hypertension, lipids, smoking, diabetes. And my rule of thumb, and the data is not terribly compelling, is that if you are a higher risk patient, you should be on antiplatelet therapy, but more aggressive evaluation in the absence of symptoms is not merited. I don't know if that gets me out of another Grand Rounds talk, but that was a pitch.
You're coming back.
Okay. All right, well, thank you all. I'll be here if you have any further questions.